Hey guys, I'm Betsy, and today I'm going to be talking about the facilitation technique of anger management. People are not born with an understanding of how to express anger properly. It rather has to be learned. Although anger is a commonly experienced emotion, if expressed inappropriately or experienced for prolonged periods of time, it can become problematic. The inability to appropriately express anger may lead to behavioral problems, including bullying and health problems, especially cardiovascular disease. Therefore, that's why anger management exists. Anger management is a psychotherapeutic program for anger prevention and control. It is the process of learning to recognize signs that you are angry or that you are becoming angry and taking action to calm down and deal with the situation in a productive way. It doesn't try to keep you from feeling angry or encourage you to hold it in. Recreational therapy approaches it in a cognitive behavioral way to help develop anger coping strategies. There are different levels and programs for cognitive behavioral interventions. The history of cognitive behavioral interventions can be traced to the early work of behavior and cognitive theorists. Cognitive behavioral interventions primarily emerged in the 1960s out of a growing dissatisfaction with the behavioral approach to psychotherapy. An experiment was conducted by Lazarus demonstrating the role of individual perceptions. The experiment found that when people were told about a stressful event, it had a significant influence on their behavioral and physiological responses. According to Menchenbaum, by the 1970s and 1980s, cognitive behavioral therapists began to argue that decision-making may sometimes be influenced by cognitively distorted beliefs. Cognitive behavioral therapists started teaching individuals strategies for identifying and exploring the reality of their thoughts. There are two theoretical foundations for anger management, which are behavioral and cognitive. In the behavioral model, behaviorists focus on overt behavior, which are those behaviors that are readily observable, while individuals internally experience covert behavior, which is any behavior that is not immediately observable. The behavioral theory stipulates that normal and abnormal behavior is learned. Therefore, a person's maladaptive behavior can be changed through a teaching-learning process that uses reinforcement to increase behaviors and extinction and punishment to decrease behaviors. The behavioral model is based on the argument that behavior is determined by external events. Cognitive theorists consider how an individual cognitively processes a situation. In the last few decades, there has been a shift from a strictly behavioral orientation for treating anger-related disorders toward a greater interest in human cognition. The basis of cognitive therapy involves the belief that people who feel depressed could feel better if their negative or distorted thinking is altered. Cognitive treatment strategies have been used to treat various psychological conditions ranging from depression to anger and aggression. Cognitive theory holds that a person's behavior and feelings are influenced by how that person perceives an event. Therefore, people can address psychological difficulties by learning to alter their thoughts. Cognitive behavioral treatment is a primary orientation of psychotherapy and is unique in that it is derived from behavioral and cognitive models of behavior. Cognitive behavioral interventions are designed to help individuals reduce angry and aggressive behavior. A selection of interventions were designed to treat individuals who are identified as aggressive and or have behavioral problems, are diagnosed with disabilities, and are adult offenders. I will be giving two examples for identified as aggressive and or have behavioral problems, one example for diagnosed with disabilities, and one example for adult offenders. So the first example for identified as aggressive and or have behavioral problems was Cole and colleagues investigated the use of a 6-week cognitive behaviorally focused anger management program titled Learning How to Deal with Our Angry Feelings with 70 elementary students, 54 being boys and 16 being girls, from the ages of 7 to 11 years old, and were identified as having anger-related problems. The purpose of the program was to assist participants in learning to develop anger coping strategies. Groups were then randomly assigned to two cohorts, the first cohort being intervention over no intervention period, and cohort 2 was no intervention over intervention period. An educational psychologist, along with a teacher or support assistant, facilitated 45-minute group sessions. Examples of topics included participants getting to know each other, understanding what makes them angry, and learning to calm down and think differently. Although results were mixed, both cohorts showed statistically significant improvements in their understanding of anger. Teacher-rated measures showed significant improvement in change in conduct problems within cohort 2. The second example for that same category is cognitive behavioral interventions have been successful in reducing aggressive behavior in adolescents with behavior disorders. Edgeit studied 30 adolescents, 24 being male, 6 being female, from ages 12 to 18, who were diagnosed as chronically disruptive as evidenced by frequent aggressive, impulsive, and acting out behaviors. The study was designed to determine if participants receiving the intervention demonstrated fewer aggressive behaviors, and the intervention would be more effective with a positive incentive. Participants were assigned to one of 3 groups, one being a 12-session cognitive behavioral intervention adapted from the anger control program, 2 being the same training program plus a positive consequence for using skills imparted, and 3 being the control group. Effects were measured by behavioral observations and teacher ratings. Behavior was observed during a 3-week pre-training period and a 3-week post-training period. Aggressive behaviors were recorded and totaled for each participant as negative physical acts, negative interpersonal actions, or destructive behavior. Teachers administered a rating scale during pre-training and again 10 weeks later during post-training. Both treatment groups displayed more self-control and fewer aggressive behaviors at post-treatment than the control group. Behavioral observations and teacher ratings revealed a decrease in attacking or attempting to attack another with intent to inflict pain, a decrease in class disruption, and a decrease in destruction of property. No significant differences were found between the 2 treatment groups. It appears that cognitive behavioral intervention was effective in reducing aggressive behavior and increasing self-control during the course of treatment. Also, the addition of an incentive program did not appear to substantially improve program effectiveness. The example for diagnosed with disabilities is that Sofronoff and colleagues evaluated effects of a 6-session cognitive behaviorally based anger management program, which was 1 time per week for 2-hour sessions, on 45 children diagnosed with Asperger's syndrome. Participants were randomly assigned to an intervention or a control group. Participants first received a workbook that included information of happiness, relaxation, and anger. Sessions included A. Exploring happiness and relaxation through group and individual activities. B. Exploring anger and the changes that occur physiologically, cognitively, and behaviorally when a person is angry. And C. Solitude. C. Participating using social skills. A. Exploring happiness and relaxation through group and individual activities. B. Exploring anger and the changes that occur physiologically, cognitively, and behaviorally when a person is angry. C. Participating using social tools, such as making social contact and avoiding solitude. D. Exploring a range of degrees of emotion using the concept of an emotion thermometer. And E. The use of social stories as a form of anger management, such as creating an antidote to noxious thoughts. And F. Having participants work together to design a program to help each better manage anger. Parents reported decreases in anger episodes and increases in confidence after the program concluded. Additional data collected from parents and teachers indicated that some of what was learned generalized to home and classroom settings. And the last example for the last category is that Valiant and colleagues investigated effects of a 6-week cognitive behavioral intervention for anger management for 1 time per week for 2-hour sessions. with 44 adult male incarcerated offenders and 26 adult male probationary offenders. The authors hypothesized that the program would have more positive effects on probationary offenders than incarcerated offenders because probationary offenders would have a more authentic desire to control their anger. Before and after the intervention, participants completed a self-esteem inventory and a hostility inventory. The hostility inventory measured assault, verbal and indirect hostility, irritability, negativism, resentment, suspicion, and guilt. Contrary to the hypothesis that probationary offenders would be more motivated to improve, they demonstrated higher levels of guilt. The authors suggested that an increase in feelings of remorse might be viewed as a positive result of treatment. Another positive effect was found with incarcerated offenders who demonstrated lower levels of verbal hostility and resentment. Caution was suggested, however, in interpreting the results. Lower levels of verbal hostility may have been achieved as an adaptive response that represented inmates' desire to complete their sentences with less conflict and interference from authority, rather than to make a lifelong change. The intervention implementation exercise I would use is Zipper strategy, which was created to help children remember how to handle an anger-provoking situation. I would use it for children with behavioral disabilities. Zipper stands for zip your mouth, identify the problem, pause, put yourself in charge, explore choices, and reset. Before the start of the Zipper strategy, participants are interviewed, offered a rationale for participation, and asked to commit to the learning strategy. Once participants sign an agreement to learn the strategy, they participate in 5 training sessions. Examples of anger management activities include practicing appropriate responses with external guidance, thinking out loud, and learning role modeling techniques. Zipper is presented as getting started, introducing Zipper, promoting cognitive modeling, practice with help, practice self-instruction, fade self-instruction, and committing to using the strategy. When introducing Zipper, I would describe Zipper steps to participants using cue cards and picture prompts. So the cue cards for Z would be in each letter would have a statement of cue cards. So Z would be stop, hand motions stop, take a deep breath, and fingers running across mouth like zipper. For the I, it'd be take a deep breath, put finger to temple, and identify problem. For P, it'd be pause, take a deep breath. The Q would be I may find a better way to handle this, and don't get angry. For P, it would be put yourself in control, stay cool. Put hands on hip, turn thumbs up, and I'm in control. E would be what can I do, and explore other options. And R would be, the Q would be I've made it, and then return to the activity. When it comes to promoting cognitive modeling, the cognitive modeling would be conducted by using the thinking out loud procedure to model use of verbal and physical cues in strategy. So the participants would choose a scenario previously identified by a participant as aggression. Then practice with help would be conducting practice of strategy steps with the TR specialist, providing verbal cues while the participant models physical response. So an example would be if the recreational therapist said, let's review the steps to the zipper. I'm going to pretend that someone has just laughed at me. Instead of getting angry and kicking the ball away from the group, I'm going to follow the steps of zipper. While I think out loud, you should show me the physical cues I taught you to remember. And then you would have children take turns, and then someone just laughed at me. I'm angry, but I know I can use zipper. And have the children or the participants each one have physical response to the strategy. When practice self-instruction, participants demonstrate use of the strategy by thinking out loud and demonstrating physical cues. Provide prompts only as needed, provide reinforcement and corrective feedback, and continue to record the number of cues the participant remembers. For phased self-instruction, participants whisper verbal cues while modeling physical cues, provide corrective feedback as in previous days, and continue to record participant performance. And for committing to using the strategy, a practice session is conducted with participants thinking steps by themselves. Participants should not move lips or say steps aloud, but should model use of appropriate physical cues, and then record performance and obtain commitment for future use of strategy.